So as we talk about these distinctive soft tissue lesions that occur in the female genital tract in this area, remember that these are not any of them very common, and most likely when you see one, you're going to have to go look and compare and learn again. So I give you this introduction recognizing that even I, when I find one of these lesions, often have to go back and say, okay, which ones are CD34 positive, which ones have this pattern, which one does this fit best with. It's natural for things that are not common like this to require checking the books. So let's talk first about aggressive angiomyxoma of the vulva. This has a scary name. Anything that says aggressive, I think we'd be concerned about. This occurs in reproductive age women, and it can occur in a variety of sites around the vulva, even sometimes in the retroperitoneum of the pelvis and so forth. The tricky thing is that these tumors are often large, but not recognized as large. So I remember stories of talking to the surgeon saying, oh, I went to take this thing out and I just had to keep going and going and going, and it may follow up into the pelvis in very unusual ways. These tumors also will tend to displace rather than invade, so that's a helpful clue. Pathologically, these are not well circumscribed, so it's difficult to know the margin status. That may have some reason, some connection to their tendency to recur. They're not very cellular, so we may even think, why did they biopsy this? This just looks like normal connective tissue. The vessels are large and small size, thin walls, thick walls, and we don't see mitoses. So is this tumor? Is this benign fibroconnective tissue? That's usually the differential. These will stain variably for smooth muscle markers, so that's not particularly helpful. Same thing for CD34, CD44. They do oftentimes have hormone receptors, and they're positive for vimentin. Those are not strong differential diagnostic clues with immunohistochemistry, although we do use immunohistochemistry to differentiate these. So here's a gross picture, and you see that it's here, maybe out here. We're not quite sure exactly where the margins are. It's not well defined as to how far the extent of this is from our surface up here down into here. And here's the low power view. Fat, some vessels, a little myxoid tissue, not very impressive. Another view, thin-walled vessels, a few thicker-walled vessels, very sparsely cellular. High-power view, again, very bland-looking spindle cells, no mitotic figures. Now, there have been a few cases where we have found a rearrangement of this particular gene, HMGA2, on chromosome 12, but not all. So if you found it, it would be helpful. If not, it doesn't exclude it. So how do these behave? Well, as you might expect, something that's poorly circumscribed may have a tendency to recur locally. And because of that, many of the initial series found a high recurrence rate. If we get the diagnosis right, though, they can do a little bit more aggressive treatment, aggressive surgery, and bring this recurrence rate down quite a ways. Some of the recurrences, however, have been late, so it is something that is a possible late, many years, like decades later. If we get the diagnosis right, they may also opt to use certain hormonal manipulations, aromatase inhibitors, or GnRH for these lesions, because they will often respond to that. And the differential diagnosis includes the other lesions that we see in this area, angiomyxoma, angiomyofibroblastoma, and then some of the other more typical soft tissue tumors like myxoma, spindle cell lipoma, and so forth. These would usually have different markers and could be differentiated on the basis of marker status and cytology. Okay, next lesion, angiomyofibroblastoma. So the name's telling us that this is myofibroblast. It's not just angiomyxoma, it's myofibroblastoma. Again, it's reproductive ages and a little bit older, and these patients often come in with a diagnosis of Bartholin's gland cyst. They tend to be well circumscribed, so there's a helpful feature grossly. And these have a unique histology, hypercellular zones and less cellular zones with those associated vessels. And there's also this perivascular fibrosis. So here you see the tumor more sharply circumscribed. You can draw the line around it a little bit more easily. And at the margin, you can draw a line. Here's a hypercellular area. Here's a less circumscribed area, less cellular area. Here's a less cellular areas, and you see this perivascular accumulation of cells. This is a little bit subtle, but once you start recognizing it, it becomes distinctive. Here again, a little bit subtle, but perivascular accumulation of these cells. These have the bland nuclear features that we saw with angiomyxoma, but there may be some cases where you have a little bit more pleomorphism and so forth. Like angiomyxoma, it's vimentin positive and may have ER/PR receptors, but it may also have some actin or CD34 and desmin. So desmin can be a very helpful marker here to show some myofibroblast type of differentiation. So desmin, sharply circumscribed angiomyofibroblastoma. Desmin negative, poorly circumscribed, aggressive angiomyxoma. So talked about this differential diagnosis. Angiomyofibroblastoma has circumscribed borders, more cellular, more blood vessels, and perivascular cells. It will be desmin positive usually. Cellular angiofibroma, we'll talk more about that in a minute. This would not have the perivascular epithelioid cells and other type of stromal reactions. Cellular angiofibroma. Okay, so no myofibroblastic differentiation to this tumor. Again, it's reproductive ages, fairly cellular, and intersecting fascicles, so a different histologic pattern. More vessels again. It's got the angio in the name. And collagen. Bland nuclei, rare if any mitotic figures, some associated fat. Well, we've seen that in these other tumors. This tumor, however, may have CD34 positivity, may have some muscle actin, but its desmin is very unlikely to have that. And it will also be positive for estrogen and progesterone receptors. So a little bit iffy in terms of how helpful this is. If you found CD34, that might help you. But mostly you're going to have to go on this spindle cells with intersecting fascicles appearance. Some of these in the larger studies have had, one that was done by Chris Fletcher and his group, have had areas of severe atypia or even frank sarcomatous transformation. So if we saw this, it should immediately take it out of the category of aggressive angiomyxoma or angiomyofibroblastoma, because those are very bland, uniform, no significant atypia. These cells are often diffusely p16 positive as well. Thankfully, however, even the atypical cases have not been shown to have recurrence, higher recurrence risk. And here's the differential. Again, these same tumors that we've been talking about, aggressive angiomyxoma, angiomyofibroblastoma. Spindle cell lipoma is very unusual in the vulva, and it could have CD34 positive cells. However, there would usually be more Phat. Solitary fibrous tumor could also be CD34 positive, but it's very rare in this area. Would probably also have BCL2 and other markers of solitary fibrous tumor. And it usually has more dense collagen and hyalinization. So here's an example. You can see how this might be seen. You see this slightly spindle fascicle appearance, streaming of the cells that suggests the fascicles. No thick-walled vessels, more thin-walled vessels, a little more hemangiopericytoma-like. So I think the differentiation from solitary fibrous tumor is actually a little harder than it may seem. Superficial myofibroblastoma is usually vaginal or vulvar and very superficial. Can occur in a broad age range. Well-circumscribed tumors, but they're unencapsulated, and they usually have a epithelial surface overlying them with a Gren zone. You know this term, Gren zone? So a Gren zone is a little zone of, if this is the epithelium on the surface, there's a little zone of normal stroma before you have the tumor. So a lot of other skin lesions have this Gren zone, or a zone of normal tissue before the tumor appears. These tumors also will be Vimentin and Desmond positive, like aggressive angiomyxoma. They'll also have ER and PR, but variable staining for these other markers as well. So it's not a highly specific pattern. It will tend to be a little bit more likely to have some of these other muscle markers, like calponin or SMA, that will indicate that it has this myofibroblast phenotype. The operative word here is superficial, and finding the Gren zone can be very useful. They're rare, so I didn't have a picture. Prepuberal vulvar fibroma is a different age group, younger. And these typically infiltrate and entrap surrounding vessels. These can be CD34 positive and may also recur. So in a young person, prepuberal, you're thinking about this rather than any of those other lesions, which tend to be older patients. So here's another image of this, hyalinized vessels entrapped by the tumor with some Phat. It's not very ugly looking. It's fairly bland spindle-shaped cells, loosely vascular, not highly pleomorphic. Granular cell tumor, our friend. These lesions also occur in the vulva. They can get to be fairly large. The vulva actually is a fairly common location for these. So 10, 5%, 15% of all granular cell tumors are located in a genital area. And they would have the typical appearance that we associate with granular cell tumor, these very granular wavy cells. So that brings us to the end of today's wrap-up. What I would like to suggest for you is that you make a little chart for yourselves of these distinctive stromal tumors of the vulva, and that you write down what the differential features are that may be helpful in differential diagnosis. I didn't put that in on purpose, but I think it would be interesting if you could take my slides, take other reading that you may do, and create a differential diagnostic chart for aggressive angiomyxoma, angiomyofibroblastoma, cellular angiofibroma, etc., and see how those things chart out. I think if you do that, you'll really learn this a little better and have less need to go back to chart to the slides the next time you encounter one of these. Okay, so any questions?